State of the Heart Care, Hospice Rules and Regulation presentation. At State of the Heart, our mission is to serve our community by providing individualized, exceptional care to patients and families experiencing a life-limiting illness, enhancing their quality of life. According to Medicare conditions of participation, a patient must have a prognosis of 6 months or less. If the disease follows its expected course of progression, they are entitled to receive Medicare Hospice, and we utilize their Part A benefit. Initially, the patient would get 90 days of service. After they are reviewed with the medical director and the team, and they meet criteria, they get a second period of 90 days. This is continued into the third benefit of 60 days as long as the patient continues to be appropriate or terminally ill, showing decline, and this recertification is completed by the medical director. The hospice medical director and the patient's attending physician are the ones that initially determine that this patient is terminal. The hospice also has to get a written certification of terminal illness for each of these benefit periods from the medical director. Any patient going into their third or greater benefit has to have a face-to-face visit by either the hospice medical director or a nurse practitioner that works for hospice. The hospice benefit is thoroughly explained to the patient so he or she understands that other Medicare benefits are waived for the primary diagnosis for which they were admitted to hospice. For example, a patient admitted with congestive heart failure that ends up going to the hospital for congestive heart failure symptoms. This would be covered under the hospice, and that the hospital could not bill Medicare Part A for this hospital stay. When patients are admitted, we are admitting patients only on the recommendation of the medical director and also in consultation with the patient family physician or their attending physician. Patients can be discharged if they move out of the service area or if they transfer to another hospice. They can also be discharged if they no longer are terminally ill and they are no longer meeting the criteria to remain on hospice. Or in rare occasions, if a patient or their family is so disruptive, they're abusive, uncooperative that we really cannot provide good care, then they also can be discharged. A patient can also choose to revoke from hospice at any time for whatever they choose, and that is just simply signing a revocation form to be discharged. The patient has the right to be informed of his or her rights, and as a hospice, we must protect and promote patient rights. One of the rights that we really need to make sure we promote and report if it is not being met is if a patient complains of either alleged or a real violation of abuse, neglect, misappropriation of property, or any kind of injuries that we're not sure where the injuries came from. We just know that this patient has bruises, fracture. This must be reported immediately to the hospice administrator or your supervisor. Initially, it's the hospice registered nurse that completes the initial assessment within 48 hours after the patient signs their notice of election that they want hospice. And then a full comprehensive assessment is completed no later than 5 calendar days by the rest of the team. And also this is in consultation with the patient's doctor. And then this includes what we call a hospice item set. It's data elements that we collect from this assessment that's included into our quality assessment program. The interdisciplinary team, or IDG, interdisciplinary group, this must include physician, nurse, social worker, a pastoral or other type of counselor. We do have a dietitian that's as needed, and we have bereavement counselors that meet with the families after the patient's death, or sometimes they meet with the patient prior to the death, and they meet with the family to address any kind of bereavement risk. The interdisciplinary group must review and update the patient's care plan no less frequently than every 15 days. And the care plan, we have to specify what services, what treatments, what interventions are going to be used for the patient. They must have measurable outcomes and goals of what we are going to be doing for the patient, what the patient's goals are, and make sure that this care plan is individualized. For QAPI, quality assessment and performance improvement. As a hospice, we must measure, we have to analyze data, and we have to track quality indicators. For example, if a patient is admitted on a narcotic, they need to have something for their bowels because we know that a narcotic can be very constipating. And so this is a quality measure that we would look for anyone that is on a narcotic, that they also have something to make sure that their bowels are going. Or that if they are admitted in pain, within 48 hours, we want their pain to be at a tolerable level. And with hospices, we also monitor the effectiveness and safety of services and the quality of our care with family surveys. We also identify opportunities or priorities that could need improvement, and that could be across any setting. It doesn't have to just be clinical. It could be finance. Finds that there's an area that could be improved, or maybe a cost-saving idea. And then also we submit patient data to our vendors. The CAP survey is, again, the family survey after the patient passes that the family can then grade us and tell us how well we performed the services, how well did we do relieving the patient's pain, how well was the patient's anxiety addressed, or their needs met after hours. Also with infection control, we have to maintain an infection control program and track infections such as the flu or MRSA, catheter-related infections, and any patient care staff or volunteer has to follow accepted standards of practice to prevent the transmission of infections, any kind of communicable disease. With our hospice aides, they have to be trained according to federal regulations. They have to also complete a full competency evaluation prior to going out on their own, and then they are evaluated by a registered nurse at least every 14 days, and that their care plan is also prepared by a registered nurse. With volunteers, we have to document how we recruit our volunteers, how we retain them, the orientation and any training and cost savings, as well as we have to use volunteers at a minimum to equal 5% of total patient care hours of all paid hospice staff and contracted employees. The board assumes legal responsibility for hospice overall operations. It is our administrator, our CEO, that oversees the day-to-day operations, but it's the board that, would look for a new administrator if needed. They approve our policies and procedures, any kind of major change that we would want to implement, it would need to have board approval. Hospices may not discontinue or diminish care provided to a Medicare beneficiary if that patient could no longer pay. As a hospice, we would still need to continue care. Also, as a hospice, we need to do ongoing education and training to make sure that employees and volunteers, whether the employees are directly employed or under contract, that they've received training on hospice philosophy and care of the dying patient, grief and loss, and things like that. As far as the organization of services, we have to have 3 services available 24 hours a day. We do have nurses that are available during the work day, and then we have a designated team that is available nights and weekends. We also have physicians that we can call on call, and also our medical directors are available to us after hours and weekends. And then also pharmacy. We have to be able to obtain medication or equipment after hours, and so we do have 2 pharmacies that we work with, Medicine and More and Couch, that we are able provide the following care and services: nursing, social work, aides. Our aides also do light housekeeping, cleaning up after themselves, maybe doing some light laundry if they created a lot of laundry during their visit. If they made a meal, they'll wash the dishes. Homemaking otherwise would be provided by a volunteer if the patient needed vacuuming and sweeping and mopping. This kind of thing. We need to get a volunteer for that patient. Counseling, we have bereavement, dietary, and spiritual counselors. Physical, occupational, speech therapy. If the patient would require those services, those are on a contracted as needed basis. We do have volunteers. We do have bereavement care up to 13 months after the patient's death. Also, access to DME or durable medical equipment, such as a hospital bed, a walker, a wheelchair, oxygen, whatever the patient needs to be comfortable. And then also any kind of medical supplies or medication that's related to the terminal diagnosis. You have 4 levels of care. The most common one is routine home care, and the majority of patients are admitted into routine home care. It's provided wherever the patient calls home. And that could be in their own private residence, it could be at a nursing home, it could be in an assisted living. If a patient requires a higher level of care, it could be general inpatient or continuous care or with respite. With GIP or general inpatient, this is for pain control or some kind of acute or chronic symptom that is not being able to be managed at our facility or at the home care setting. It's not intended for respite, if the family needs a break, or a way to address unsafe living conditions. The patient can no longer live alone is not a reason to bring them into the inpatient care. The picture you're actually seeing is our front desk of our inpatient unit located on the 4th floor of Wayne Hospital. And it has a 5-bed unit that, again, patients that are currently on the program can go into the unit to get their symptoms under control, or we can get referrals from area hospitals, nursing homes to admit that patient directly into hospice into the unit to get their symptoms under control. Crisis care is for a patient that is out at the home and they're having an acute symptom that needs to get under control, but they really want to be able to stay at home. So this might be something that we try before they go to the inpatient unit. We try to get them controlled at home. Nursing has to provide a minimum of 8 hours of care during a 24-hour period from midnight to midnight. It can be RN, LPN, and also we can have a portion of those hours covered by an aide. But it must be provided by employees of the hospice and cannot be contracted agency staff. Also, staff has to document at least every hour during care. The nursing services must comprise more than half of the care, and the hospice aide can comprise up to 49% of that 8 hours. Respite care is to provide rest for caregivers in the home. That they've been caring 24/7 and they just need a break. Maybe they have an out-of-town wedding, or they just need a few days to get some rest, to be able to bring the patient home and provide continuous care with, continual care with them. It is provided in a contracted inpatient unit, or it could be a nursing home that we contract with. It is up to 5 days at a time, and it's just on an occasional basis. And because it is a break for the family, nursing home patients cannot utilize respite. For payment of hospice, currently it is on a per diem or a daily rate for every day that the patient is on. It is 2 tiers, meaning the first 60 days is a base rate. Then starting on day 61, the rate decreases. But during the last 7 days of life, the hospice can add what we call a service intensity add-on. And if the social worker or a registered nurse visits, we can count up to an additional 4 hours of service add-on. Hospice in the nursing develop a coordinated plan of care for each patient. We also have to identify who's responsible for the specific intervention. And then any changes that is made to the care plan must be discussed with the patient or his or her representative.
Thank you for listening to the Hospice Rules and Regs. This is the conclusion of the program.